Some of the other abstracts that we're presenting here at ASH, one of them is looking at this challenge of response. So, I think that in MDS, we are using response criteria that have been around for a long time. There is some rationale to them. We know that patients who get a CR, which is a pretty strict definition for MDS, but we know patients who get a CR, they really seem to have the best outcomes. And prior studies have shown that there's a survival benefit associated with those patients who do achieve an optimal response or a CR. The problem is that very few patients get that. So maybe 1 out of 5 patients with MDS treated with azacitidine or decitabine will achieve a CR. And so how do we identify meaningful responses that may also have benefit and might also indicate a group of patients likely to do well? A challenge in this space has been this idea that we often look at blast reduction separate from how blood counts improve. And so if you look at marrow CR, that can mean somebody has reasonable blood counts, is not coming into the hospital very often for transfusions, is not requiring hospitalizations for infections, and has a reduction in their blasts. Or it can be a patient who's pancytopenic, who's needing chronic transfusions, whose their blasts are gone, but really they don't have much marrow to speak of at all. And so can we look at different types of outcomes as meaningful responses in MDS and try to use that to inform how we design trials? And one response that has been developed really in acute leukemias where you have MRD assessment is this idea of complete remission with hematologic improvement, or CRH. It makes sense in some degree. You have a reduction in blasts as part of it, but then you have enough platelets and enough neutrophils, a platelet count of 50 and a neutrophil count of 500 to be safe on your own outside of the hospital, not need transfusions as often, not run into bleeding or infectious issues. And so clinically it kind of makes sense as a step. So we looked at reclassifying patients who had marrow CR, stable disease, as CRH. And what we found is that CR still had the best duration of response. CRH was a close second, but both of those responses were better than other responses in MDS. And an interesting, although small, observation was that the survival between patients who got CR seemed very similar to patients who got CRH, and both of those responses were better than patients who had other responses. Patients who achieved a CR or CRH had a similar overall survival improvement compared to others. Now, this is the work of a few collaborating institutions, and so we'll want to reproduce this in a larger scale. I think another thing we really want to ask is, what's so special about a platelet count of 50? Would 30 be just as good? Do we need to go to 75? Same with a neutrophil count. Is 250 similarly beneficial compared to 500? And so one of the things we'd like to look at is more of a range of, can we really define what outcomes, what responses to treatment are meaningful to patients and are something that we should really aim for when we design a clinical trial. And so I'm hopeful that that kind of work will be something that we can really impact the way we design trials in MDS eventually.